Pain is a complex phenomenon in which every individual experiences differently. Effective pain assessment and management during the postoperative period impacts upon a patient's recovery journey on many different levels. Despite the many clinical advances in pain management during recent years, evidence suggests that pain is undertreated during the postoperative setting. Throughout this podcast, we will explore this issue through a situational analysis, compare evidence-based interventions to current practice, and highlight ways in which our clinical practice can be improved. So what is the current issue? Despite the availability of successful evidence-based interventions, inefficiencies are evident within the assessment and management of postoperative pain. Who is affected by this problem? 50 to 75% of surgical patients report of having moderate to severe pain postoperatively. Within this cohort, patients such as opioid-tolerant, pregnant women, cognitively impaired, culturally and linguistically diverse, and children are at particular risk of inefficient pain management. In what context are we facing this issue? Poorly assessed and managed postoperative pain has negative physiological and psychological impacts upon the patient. Furthermore, it extends one's length of stay in hospital, contributes to patient dissatisfaction, and delays patient recovery. So what factors can facilitate change? Having a patient-specific approach, conducting comprehensive pain assessments throughout one's entire perioperative journey, a collaborative, multidisciplinary and multimodal approach, and increased education for both patients and healthcare professionals. One's pain experience is comprised of both emotional and sensory components. Effective postoperative pain management begins with a comprehensive assessment and development of a management plan prior to the surgical procedure. This assessment is tailored to the individual's needs and examines the specific surgical procedure, the patient's preoperative medical and psychological status, their age, current use of opioids, their analgesic preferences, expectations, and the consistent monitoring of their response to analgesic agents throughout the perioperative journey. This approach considers the whole person with regard to the many subjective influences that shape one's experience of pain. Regular pain assessment across the continuum of care improves outcomes of postoperative pain management. Furthermore, pain is most accurately assessed when the tool is appropriate for both the patient and the context in which it is being used, taking into consideration the individual's cognitive ability, emotional status, cultural background, and any other communication barriers. In addition, pain scoring should incorporate more than a numerical severity rating, but further include a patient's functional capacity and whether the pain is of a static or dynamic nature. Finally, a patient's self-report of pain should be taken seriously, as pain is a subjective experience. Within the landscape of our current clinical practice, pain assessment is widely based upon the use of pain severity rating tools. These tools have limitations as they do not consider the whole person or their presentation, location, duration, or onset of pain. Furthermore, in a survey conducted by Francis and Fitzpatrick, it was found that nurses significantly underrate the pain of their patients compared to the patient's account of their own experience of pain. This emphasizes the importance of listening to a patient's self-report of pain and making clinical judgments based upon this for the way their pain is managed. Current evidence suggests that the management of postoperative pain should first and foremost be patient-centered and tailored to individual need. From this, a management plan can be developed that incorporates a multimodal approach to analgesia and procedure-specific management. Furthermore, current literature demonstrates that consistent communication between the patient and all multidisciplinary team members during the patient's perioperative journey enhances one's outcomes of postoperative pain management. Despite the clear evidence to support these interventions, there is a current gap between research and what is clinically practiced in our hospitals. Current practice widely observed in Australian hospitals relies heavily upon pharmacological-based interventions for pain management, in particular the use of opioids. This is a current issue as rates of oversedation, respiratory depression, and opioid tolerance are at an alarming high within the postoperative setting. Furthermore, the diagnosis of postoperative neuropathic pain is often delayed, which when untreated is a risk factor for the development of chronic pain. In addition, decisions regarding the patient's pharmacological management are often determined by the pain team without direct consultation of the patient or nursing staff involved in their care. This does not reflect a patient-centered approach and is a barrier for consistent multidisciplinary communication. This brings us to the question, why does this gap in research to clinical practice exist? The main reasons reflect a certain segregation of the preoperative, intraoperative, and postoperative period, and the subsequent lack of efficient communication by the clinicians during each stage. Furthermore, evidence suggests that pain is infrequently assessed and poorly documented. This is problematic when multiple clinicians are involved in the delivery of care, as crucial information is lost in the process, having negative outcomes upon the way in which a patient postoperative pain is managed. Furthermore, lack of patient involvement in their decision-making and care plan is the primary reason for patient dissatisfaction regarding their postoperative management. Improving future practice requires changes to be made which involve the patients and their families, healthcare clinicians, the organisation of facilities, and the subsequent delegation of their funding. Efficient and consistent pain assessment is crucial to the successful management of postoperative pain. Thus, my recommendation for future practice is to develop a standardised assessment tool that is implemented at regular intervals during the preoperative, intraoperative, and postoperative phase. This tool should incorporate more of a subjective picture of pain, in contrast to pain severity rating tools. The reviewing of this assessment should be part of the handover process to ensure consistent communication across all clinicians during the various perioperative stages. In conclusion, the management of postoperative pain should always be patient-centered and tailored to one's individual need. This begins with a comprehensive pain assessment prior to the commencement of surgery and reassessed throughout one's perioperative journey. Current gaps exist between evidence-based research and what is being clinically practiced. These gaps can be overcome through efficient pain assessment and enhancement of communication between the patient and all multidisciplinary team members.